Good evening, everyone, and welcome to our IVF webinar. It's my IVF Fences. I am Caroline, your host, and it's great to have you here, that's for sure. And of course, as you can see, we do have a special guest, and tonight we have another interesting topic on genetics. Again, as you know, we are continuing on the topics on genetics already, and I'm very pleased to see another member of Vistahermosa Clinic. So this is Dr. Antonio Urbano. You can see him right here. Hi, Dr. Antonio. How are you feeling tonight?
Sorry. Hello, Caroline. Thank you. I'm fine. And you?
Very nice, and I'm very happy and excited to see what you have prepared for us. And also there is a coordinator with us tonight supporting Dr. Antonio. This is Marta. Hi, Marta. Hope you are well, and thank you so much for joining us tonight as well. How are you feeling tonight? I hope you are well as well.
Hi, Caroline. Thank you so much. We're doing well here in Alicante, so looking forward for this evening.
Perfect. Thank you so much for accepting our invitation and, of course, bringing this topic, genetic carrier screening. And just so you know, as I've mentioned, Dr. Antonio is a member of Vistahermosa, and he's the geneticist. And he will talk about this topic tonight. He will start with his presentation. But afterwards, as always, it will be time for your questions. So all you will need to do is just type the questions in the chat section, and then Dr. Antonio will definitely answer them for you. So don't hesitate. Anything that's on your mind, go ahead, do it. This is your time to use. This is your time to ask your questions. This is your time to find out a bit more on genetic carrier screening. So I can only encourage you to type the questions in the chat section. And of course, it's being recorded. So remember that if you need to, hope not, but if you need to leave or anything like this, you will be able to watch the recording next day. Of course, it will be available on my IVF Answers. And that will be it from me. I think we can start with the presentation, right, Dr. Antonio? Ready?
Okay.
Perfect.
Thank you.
Let's go ahead then.
Thank you, Caroline. Good evening to everybody. My name is Antonio Urbano. I'm the head of the area of the health molecular and pre-implantational diagnostic at UR Group UR International, UR International Group, and we're talking about genetic carrier screening. Okay. First of all, we have to answer this question. What is carrier screening, a genetic carrier screening? The genetic carrier screening has one objective. This objective is to identify high genetic risk couples based on the carrier status of the member of this couple. And we can planning the final goal, the final objective is to planning correctly the pregnancy of this couple. I would like to remember how hereditary diseases are transmitted. The human being has two alleles for every gene. To facilitate the understanding, one inherited for our father and one inherited for our mother. In regard to inherited disease, we can distinguish at least three types. Okay. The first time, in first place, we have the autosomal dominant disease. This disease is characterized because the patient has the pathogenic variant in one of the two alleles. This is enough to cause the disease. So the carrier of these pathogenic variants will develop the disease. Transmission of the pathogenic alleles occurs in 50% of cases. So the half of the patient's offspring, regardless of whether they are male or female, will be inherited and develop the disease too. For example, Huntington chorea, Marfan syndrome. These diseases are out of focus of in the genetic carrier screening because usually the patients already know their carrier status. For the autosomal recessive condition, variants occur in both copies of the gene. Okay, in both copies of the gene. The parent of an individual with autosomal recessive condition each carry one copy of altered gene, but the typical do not show signs or symptom of the conditions. Okay, they are silent carriers of the disease. Sorry. Autosomal recessive disorders are typically not seen in every generation of an affected family. Offspring have a 25%. One of 4 members of the offspring is at risk of inherit these diseases. At least, and the last one, the last inherit that we see now is the X-linked recessives. The risk to the offspring depends on the genetic status of the mother. Okay, is this case of the mother. Heterozygous females have a 50% chance of transmitting pathogenic variants in each pregnancy. Sons who inherit the pathogenic variant will be affected. Daughters who inherit the pathogenic variants are heterozygous and usually asymptomatic carriers. Males with X-linked diseases, all of their daughters will be heterozygous for these conditions, and all her sons, all his sons, will be healthy. Sorry. Here we have data where demonstrating the importance of genetics. Genetics matter. 25,000 conditions with genetic basis. 10,000 monogenic conditions, 1,300 conditions with recessive and X-linked inherited. It could be transmitted by healthy couples without previous clinical history. This is the aim of the genetic carrier screening. 3 of each million newborns are affected by this condition. And it's important that up to 40% of pediatric emergency cases and up to 7,100 of pediatric hospital admissions are of genetic origin. This is that 2 or 3 of each 100 couples are in high genetic risk. High genetic risk means that both members of the couple are carriers of pathogenic in the same gene that could be lead of the first offspring affecting with the disease. If we pass a commercial filter to this data, we have this slide. Okay, this slide demonstrates that we have previously. One of the most frequent couples is the Down syndrome, and the Down syndrome have a change to 1 in 800 instead. The risk to have a Down syndrome is 1 in 800. Instead, 1 in 300 pregnancy are in risk for this condition that we have just seen. Okay, and how many and which disease should be included? Sorry for the errata. This should include in a carrier screening. This is one of the most important questions to answer. We have to select the correct disease to offer couples a balance between genetic security, price, and time, and above all, using the common cells. Today, it is possible to sequence almost all genes in the genome, but it doesn't make sense to do so at least now, because it's expensive and time-consuming. This question is not easy to answer, and I think that is not only a one correct answer. It is important to follow the international society guidelines and use the experience of each laboratory in the realization of this kind of analysis, kind of test. Here we are some international or the most important international society that they have their recommendation on which disease should be included in the carrier screening. Let's see a brief summary of the recommendation. What disease to include? it's very important that the disease to include have a prevalent and several recessive X-linked hereditary disease. The disease must be chronic, severe, or progressive disease with sensory, motor, or intellectual involvement and with a clearly established phenotype. This recommendation for the disease that must include, but we need some recommendation for what variants of this gene we have to include, because we have to include in this carriers screening variant of clearly biological significance described as pathogenic or probably pathogenic. A variant of pandemic distribution universal, okay, regardless of the geographic origin of the donor that we did in the past. As important as the inclusion criteria are the exclusion criteria. The exclusion criteria are the variants of disease of which there are highly unpublished cases with little information on survival, with variable in expression and incomplete in penetrance. In summary, we don't have to include disease that we don't know the function of the gene. Genes that are associated with a spectrum of clinical manifestations, especially when there is no phenotype-genotype correlation, and there are also different manifestations with the same family. Okay, variants of risk factors. These are pathogenic variants of low penetrance that condition are increased into the relative risk to develop disease. Disease of dominant mitochondrial, non-Mendelian or polygenic disease. Variant related to benign disease and of uncertain significance or loose with or without clinical evidence that the pathogenic effect. Does the number matter? More is not always better, okay? But still, how many diseases need to be studied? And even if it is seems otherwise, not always more is better. That we will see just right now. The most important criteria is the severity and the prevalence of the disease, since only severity disease and with high prevalence in the population will be included. But in case of prevalence, is considered high, and therefore, what will be the threshold of them? Okay, this study from Dr. Matsey showed the number of the disease that meet these two criteria, severity and prevalence, and is reflected in the graphic. In this graphic, we can observe that if we set the threshold in 100, there is 18 conditions that involve that we can detect 84 at-risk couples. Okay, but if we lower the threshold to 1 in 500, 1 in 500, we have 91 conditions, and we can detect about 95% of at-risk couple. So it seems to feel like a parent with around 10 diseases could be adjusted to the needs of most couples. We can see here the most prevalence and severity disease that like cystic fibrosis, deafness, beta thalassemia or sickle cell anemia, phenylketonuria, okay, also Smith-Levy syndrome. And another factor that we have to consider is depending the number of genes we include in this study, we will increase the probability of finding pathogenic variants in the patients. Okay, as you see in this graph, if we study 549 genes, the probability of the patient have at least one variant, pathogenic variant, is 84%. This number is low. If we study 200 genes, we have a probability of 56%, And if we study only 15 genes, we have around 20% to we detect about 20% pathogenic variant in our patients. And we are seeing, sorry, in this gene, sorry, these 15 genes that expose around 20% of this pathogenic are the same genes that we previously seen in the study of Dr. Mansi. Okay, that all of these genes have a prevalence less than 1 in 100. One important thing is the market of genetic carrier screening, and if we look at the market of the genetic carrier screening, we see that there is a great variability in the number of genes that are included in the different studies. Of all these panels, 89% are coinciding in all of them, which coincidentally are the same that we saw that 91 genes from the Dr. Matsi study. Below, I show you some panels, a sample of panels. Okay, we have seen two panels, one basic panel. This is this is the little one. Only have 38 genes divided into two panels basic, because if we study a male, we only study 15 genes, and if we study a female, we can study these 15 genes more, adding 23 genes X-linked. Sorry, and we have an expanding panel. This expanding panel, we use the whole exome technology, and are about 552 genes. Okay, and the most important thing is that it's compatible with all panels on the market. As we've seen before, existing is genetic carrier screening providers match 89 genes, but there are 830 genes that don't match. This can be a problem for a couple who have performed this test at two different sites, as they may be carriers of pathogenic variants in genes that are not included in the panel performed. That is, a member of a couple may be a carrier of pathogenic variant in a gene that is not included in the other test that the partner done. This can be solved with this whole exome technology, so we will have the information of almost all of the gene of the existing genes. In our center, we use this technology as a guarantee of compatibility of all the genes, of the existing panels in the market. There are the genes included in the panel, in the basic panel. Okay, with this, the typical and the prevalence of this of carriers. Okay, in Caucasian or European ancestors people. We have cystic fibrosis. We have deafness, sickle cell anemia, spinal atrophia.
Muscular atrophy.
Thank you very much. Sorry. And the panel for extended to X-linked genes. Okay. Now we have hemophilia and Charcot-Marie-Tooth, and of course X-Failure syndrome. How do we do it? We have presented an example panel, but how do we do it? The basic panel, by including a small number of genes, uses a closed panel. This is a target targeted planet that is close, which allow us to reduce cost, but we don't have the flexibility that we have with the expanded panel. Why? Sorry. We have already commented that in our laboratory we use the full exome sequencing technology for a matter of compatibility with other tests, but we also do it for a more weighted criteria. Thanks to the whole exome sequencing, we can reduce the residual risk. In the residual risk is the risk that remains after a negative result in the test performed. This residual risk is much lower when we perform a complete sequences of the gene and not study an aiming at certain mutation. This may suppose risk to be taken into account, especially in disease with a high rates of carrier, but which doesn't have well-defined all pathogenic variants. In addition, we must always take into account the limitation of MGS, the technology used for this panel, as emphasized in these complementary studies. Okay, where we do triplet expansion in the case of fragile X syndrome, and copy number variation for the study of spinal muscular atrophy or alpha thalassemia, for example. And of course, for a complete study of the couple, a fundamental test to perform is the karyotype, which allows us to detect chromosomal anomalies in couples, which normally go silent until the moment of the reproduction, and it can lead to repeated miscarriages or implanting failures. And it is highly recommended, I will say almost mandatory, the realization of the karyotype, in addition to the screening of the genetic carrier screening before the start of the assisted reproduction cycle. When and how to do an expanded carrier screening or genetic carrier screening? Well, the best time, obviously, is to do it before starting the assisted reproduction cycle. Okay, and we can do it sequentially. That is, the first of one member of the couple and then the other, or simultaneously. If we do it sequentially, we could save some money, because, as we have already seen, the chance of finding a pathogenic variant is high. But if we do it simultaneously, we will surely save time. Okay. In case of doing it sequentially, we must start studying women, because this way we study X-linked diseases. If the result is negative, it can be established as a low-risk couple, but if the result is positive, the study must be done in the male to check if the carrier is a carrier of a variant in the same gene. Sorry. And now is a new trend I want to introduce, that is the genetic matching. Okay, which is the concept, which is making sure that the couple does not share pathogenic variants in the same genes. This concept is particularly interesting in the case of the gamete donation, because the couple gets the greatest genetic security we can offer. Although, unfortunately, the risk today is never zero. Okay, we can reduce it, but we can never goes to zero. This is a scam that the possibility that we find when do the sequential study. Although it's also applicable to simultaneous study. First, we can study a woman, include X-linked genes, no pathogenic mutation or no pathogenic variation. We can continue with the cycle. If we detect a pathogenic mutation, we need to study male, okay? And if the male has no mutation in the same gene, is considered a low risk couple, and we can continue a cycle. And if they share the male have a mutation in the same gene, there are a high risk couple. Okay, It should be noted that although the couple is a high risk, we can offer some solution to this couple to be able to have healthy offspring, either through pgt-m, okay, or through a gametic donor. Since our goal is that the couples have a healthy child at home. In the case, in this slide, we have the management of a couple who perform a cycle of gametic donation. Okay, both the parent, the patient, and the donor perform the same test, or find that a compatibility test is performed, thanks to the West or whole exome technology that we have explained above. If they don't share pathogenic variants in the same genes, sorry, if they don't share in the same gene, this couple of patients and donor are low risk, but we always take into account the residual risk, since we cannot offer the risk zero. Okay, if both share a pathogenic variant in the same gene, it's considered a high risk partner and couple, and the donor is changed. In this case, we change the donor and we're looking for a new donor compatible with the patients. And in the case of a female donor, and we found an X-linked gene pathogenic variant, we discard the donor. This donor can't donor her gametes. Okay, for the last, and finally, here we few ideas that they would like to see as conclusions. Okay, a couple has about 1 to 3% of chance to be high genetic risk, that is to share the pathogenic variant in the same gene. The probability to detect a pathogenic variant is greater the more genes we study. Genetic carrier screening or expanding carrier screening allow to reduce the risk of couple of having offspring affected by recessive and X-linked disease study. As a result of preconception genetic testing and subsequent informed family planning, a reduction between 47% and 19% was reported in the incidence of serious monogenic conditions such as cystic fibrosis and beta thalassemia. It is a screening method, not diagnostic. Not all genetic diseases that exist are studied. If a member of the couple carries a recessive mutation, genetic matching can be performed. If the woman carries a X-linked, pgt-m, or gametic chain must be done. All donors in the group are studied. Our group are studied with the same panel as the patients, and our expanding panel is compatible visually with everyone on the market. Thank you for your attention. That's all, and I want to show you the last image.
And thank you, Dr. Antonio. Thank you so much for your wonderful presentation. You are looking for something. Can you tell me?
The doctor was looking for an image to show, but he has left it out of the presentation. So don't worry.
Oh, I think it's right here. This is the one, right?
Sorry.
Perfect. Thank you so much indeed. So this is, yes, thank you so much for bringing those nice pictures here as well, of course, and for this wonderful presentation. That was definitely interesting with lots and lots of details. And of course, genetics, I think in general, are not easy topics. So I'm very happy that you have been able to put it. I think it was understandable for everyone here as well. And right now it will be time for your questions. So as always, don't hesitate. Just go ahead, type those in. Anything that's on your mind, just type it in, and Dr. Antonio will be happy to help you out. And of course, Marta is here to help as well. Okay, let's have a look. Okay, Dr. Antonio, the first question we have from Derek. So let's have a look at this. So what do you suggest for a procedure if there is mitochondrial disease?
Okay, Caroline, thank you, Derek. This question and the next one that I see in the screen is have the same answer. Okay, this carrier screening is not the aim that the mitochondrial disease, and is not the aim for patients that have family history. Okay, this is for patients that don't have any familiar history, and I asked my colleague Marta to help me. Okay, no está enfocado a ese tipo de pacientes, ¿vale? Es decir, lo que vamos a hacer es para población general, ¿vale? Para que son enfermedades prevalentes en la población general que no hay historia familiar.
So the genetic carrier screening is thought for patients who do not carry any diseases, and it's to screen the general risk of being the carrier of those diseases. So it's not a specific study, it's a general study to reduce risks.
Yes. Okay. For mitochondrial disease, we have to we can do a panel specific for mitochondrial disease, and if the patient have a family history, we do a genetic counseling, and we can study this disease in specific conditions. Okay.
All right. Thank you so much, of course, for explaining how it all works and for your question. So this one, actually, yes, it's you already kind of answered as well, correct? All right. So at this point, at least, we need to wait for a bit for some more questions. But in such case, I would have an additional question from me. Okay, if you can tell us, because is genetic testing like? Do you think it will be something that will be more and more recommended to all the patients?
I think that is recommended. I think that is mandatory because there are diseases that one person of 25, 21 people have this are carrier of this disease, and this is a tool that we can use to facilitate the objective, the final objective, that is have a healthy baby in your home when you start a reproduction cycle. Okay, this is the only way to darles máxima seguridad.
Give them the only way to give them most security.
Most security, for genetic security. This a lo mejor como decimos en termómetro. A lo mejor no es un término correcto lo de la seguridad genética. Perhaps it's not a correct term, the genetic security, okay? But it's the closest term that we can use, okay? That I think it is very, very recommendable to do this carrier screening. At least the 15 more prevalent disease. Okay?
Of course. Thank you for the clarification. So it's something that definitely should be checked, because that way we can like decrease the chances of some other problems in the future as well, right? And also, so at least basic panel you mentioned, right? So what about this expanded? In what cases, in such case, the expanded panel you would suggest?
The expanded panel it's more complicated to defend. We can see in marketing on web page, internet. We can see some providers that have 1,000 genes, examined 1,000 genes. If we follow the International Society's recommendations, we don't have to do so many genes, okay? Because in 1,000 genes, you have genes that don't no cumplen, ¿no? ¿Cómo es?
Don't fulfill.
No cumplen las recomendaciones, no cumplen.
They don't fulfill the recommendations of the international society.
Okay. Say, for example, decide that are not a severity, severity disease. This is one example that está más que demostrado que no hay que incluirla.
When there are non-severe diseases that has been demonstrated that shouldn't be included.
Como alfa-1 antitrypsina, eso se llama, ese nombre. Alpha-1 antitrypsin, it's including some panels that it's all the society, all international society said that you don't have to include this disease because if you are enfermo, pero ill, but no, see, if you have two mutations, two pathogenic variants of the gene, that no te asegura,
Doesn't ensure
that no te asegura que vayas a estar enfermo.
Even if you have two mutations of that same gene, this does not mean that you will have an illness. So you can be a carrier but not be ill.
Carrier of two mutations.
Of two mutations.
Lo que generamos es un problema.
And in that case, we would generate a problem and not a solution for the situation.
Yeah, because we can't predict the phenotype if the child will be ill or healthy.
All right. So, of course, it's thank you so much answering my additional questions as well. And one more question is right here from Derek. So let's have a look. What do you think about the best PGTA testing?
I don't know what Derek ¿qué quiere decir?
What does Derek mean with best PGTA?
Yeah, PGTA is a technique that all the laboratories, almost all laboratories, do the same with the same technique and the same technology. It's true that a few years ago we could use an array of CGH, but nowadays all the laboratories use NGS. I don't know if this is the question, or I don't know what.
Derek, if you can let us know, but of course, in such case, all the clinics, I guess, use this newest technology, NGS technology, right?
The best nowadays, the best you must do the PGTA with NGS because it's the only technology that permits you detect 20% of mosaics. That is the critical point, the critical topic in the PGTA nowadays is the mosaics, and only NGS have the potential to detect this 20%, 30% of mosaics of every embryo.
All right, understood. Of course, Derek, if you would like to add anything, go ahead, type this in. Okay, so I only have one more question for you. I'm still waiting for some more. But so what happens if, for example, patient has learned that he has some carrier diseases, is a carrier of some genetic diseases, and how does it work? He has like a consultation. How does it work from that part?
Yeah, here in Vistahermosa, in the UR Vistahermosa, we have I'm the geneticist from the group. Okay, we have a genetic unity. Okay, and the patient have the genetic counseling, and we have vamos a hacer consulta, seguimiento y de asesoramiento genético.
We have an appointment with patients. For international patients, we usually do video consultation with the geneticist, where patients are given the options that we have to help them out with their problem.
All right. Thank you so much for that additional question once again. At least for now, I do not see more questions. So I guess everything is very clear for all of you. And I hope that it has been useful for you. I do believe it has been useful for you because, of course, this is a topic that it seems that everyone needs to look at. Yeah, this is something that can happen to anyone in this case. I mean, when it comes to that. So we will be finishing for tonight, as I do not see more questions. However, I just want to add that if anyone would like to get in touch with Dr. Antonio or his team at Vistahermosa, or Marta, of course, I'm sure she'll be more than happy to help you out as well. So don't hesitate. You can ask. You will be redirected to the site. Dr. Antonio's profile on our site, and there is an option to contact Dr. Antonio, and I'm sure he will be more than happy to help you out with some maybe questions that you might have later on. And before we finish, Dr. Antonio, is there anything you would like to add?
Thank you so much. It's a pleasure for me. I'm sorry for my English. It's very difficult for me, but it's a pleasure.
It was a pleasure to have you here. And of course, this is your first webinar, I know, in English, but don't worry. It's just, I'm sure there will be more to come. And as we always know, the first time is the worst, and then it's just getting easier and easier. So thank you so much still for being here with us, for asking your questions. And of course, as I mentioned, if you would like to get some more details, you can go ahead and ask. But as you can see, Dr. Antonio, Derek would like to thank you for answering his questions. And also, I would like to, sorry, someone is typing. I just want to make sure whether it's another thank you. Okay, see, there is a... Thank you so much indeed. Marta, thank you for assisting as well. And as I mentioned, it has been recorded, so you will be able to have a look. You will be able to see it on our site. It will be available, and so go ahead and subscribe to our YouTube channel. That way you will know that the video has been uploaded. And thank you, Dr. Antonio, Marta. It's been great to have you here. Thank you for bringing again this excellent presentation and for answering the questions. Have a lovely evening, everyone, and I do hope to see you both back here as well. Thank you so much.
Thank you.
Caroline.
Thank you, Caroline.
Bye.
Thank you. Bye.